Okay, hi everyone. Welcome to our 25th session of the MedAI group exchange sessions. And this week we have Sarah from Stanford here with us to present her research on training medical image segmentation models with less labeled data. Sarah is currently a PhD student at Stanford, where she is co-advised by Chris Ray and Curtis Langlots. She's broadly interested in applying machine learning to meet needs in healthcare, particularly those that make healthcare more accessible. So thanks so much, Sarah, for joining us today. And before we get started, do you have any preferences on how you'd like to take questions? Can we interrupt you, or do you prefer it all at the end?
Yeah, please interrupt. I think my slides should only take about 30 minutes or so total, so interrupt as I go. I think we should have plenty of time.
Awesome. Okay, so let's try to make this as interactive as possible. And without further ado, let me hand it over to Sarah.
Awesome. Well, thank you for the intro and for the invite. So I'll be talking today about methods we've developed to train segmentation neural networks with less labeled data. This has been joint work with many others here at Stanford, as well as some external collaborators. We work with some great folks at the NIH, NHLBI, and various cardiologists who helped us collect and analyze data. So I'm going to start now with some background and motivation for our project. This is probably going to be familiar to everyone in this audience, but might be useful to go through for a few minutes just to kind of lay the foundation of what we're doing. But deep learning-based medical image segmentation models have a lot of potential use cases. Perhaps the most obvious set of use cases are to automate tasks that doctors are already spending time doing. So when you have a medical image, a lot of times the way that you can get quantitative information out of that medical image is by applying some segmentation mask. So for example, in this cardiac image here, where you can see a heart imaged, we have some doctor who drew a segmentation mask around the, Sorry, is there a question? Okay. We have a doctor who drew a segmentation mask around the left ventricle. And so from this, you can compute quantities like what is the volume of blood that the left ventricle is holding, or how much blood is it pumping out each cycle. Similarly, you can segment tumors. So you can look at things like the volume of the tumor and how it changes through therapy or maybe after therapy. And typically manually drawing these segmentation masks is a very tedious and time-consuming process. So by automating it, you have the benefit of reducing the time it takes to analyze one of these images. You also reduce the observer variation. So with segmentation masks, typically if you ask 5 different cardiologists to segment the same heart, they'll often come up with pretty different segmentation masks. So by automating it with the same system, you can get the same segmentation mask every time. And then there's also this opportunity to train kind of more segmentation masks for more tasks than are already being performed. Because segmentation is so time consuming and tedious, there aren't a ton of segmentation tasks in kind of standard clinical practice for analyzing images. But if we automate it and we make segmentation super easy, potentially there's more informative values that we could get out of these medical images. Another bucket of use cases is to provide location information to kind of complement classification networks. So a lot of people train medical image classification networks to say things like, a chest x-ray is positive or negative for a pneumothorax, or medical image is positive or negative for a fracture. But just that, standalone classification label isn't super informative in terms of where pathology was found. There's a lot of work going on in this direction of making classification models more interpretable, but kind of one option is to jointly train segmentation models so you can provide this kind of informative localization information about pathologies found in an image. So given these different use cases, there's a ton of segmentation targets that people train models for. So there's different structures, both anatomical and kind of pathological, so segmenting different organs in the body, or segmenting things like tumors for diagnosis or therapy monitoring. For all of these structures, you can image them in different imaging modalities or with different sequences. So one good example of this is cardiac MR. The heart can be imaged with many different cardiac MR imaging sequences. And so you really would need kind of a separate network to segment the ventricles of the heart for each type of cardiac MR image. Beyond cardiac MR, there's cardiac CT, cardiac ultrasound. So we have this kind of like exponential growth almost of networks we might have to train for many different structures and many different modalities and imaging sequences. But beyond that, we want our networks to be robust to different patient populations and different imaging equipment that you might find in different hospitals. So this is a pretty huge problem space, right? We want to train networks for many different structures over different modalities, and ideally train and test them on different populations and different institutional data. And labeling data to train such kind of a breadth of networks is really not feasible. Generating labeled training sets for segmentation is super expensive. They're not things you can pull from the EHR report. They're not typically stored in an accessible way in the PACS. So typically, if you want to train a new segmentation network, you need to go find a radiologist or some sort of expert to go and manually label your data for you. And so we got interested in exploring different ways to use unlabeled data to train segmentation networks instead of relying on labeled data. We started this kind of general line of research a few years ago. And the first thing we did was work on extending kind of a weak supervision framework, for those familiar with that set of approaches, to the segmentation use case. And this is something that we published this year at iClear. But since then, I guess we initially submitted that iClear paper about a full year ago. So since then, we've been working on kind of an updated, more semi-supervised pipeline, which is what I'm going to be talking about today. So the next section is walking through what the semi-supervised pipeline looks like. I guess first to kind of give the setting. So we do require access to some amount of labeled data. So I'm going to call that labeled data set S. And so this labeled data set has pairs of images and segmentation masks, or X and Y, that were labeled by an expert, but it's, ideally from the user point of view, it can be pretty small. So something like 10 patients of labeled data. And then we also assume we have access to a much larger set of unlabeled data, D. So D just has the images, or X, and these are much easier to accumulate, right? You can just pull them from the PACS without additional manual labeling burden, or maybe there's a public data set you can use. And our goal is to use these two data sets, the labeled data set S and the unlabeled data set D, to train some segmentation network F. And on this side, I'm going to kind of give a very high level overview of what our approach is to train segmentation networks with S and D. And then in the next few slides, I'll give more detail. So in summary, the approach we ended up with after this kind of year of research is a two-step process in which we use many different types of model supervision to kind of squeeze out as much signal as we can from the labeled and unlabeled data. So we combine data augmentation with a kind of a traditional supervised loss with self-supervised learning and pseudo-labeling all in the same framework. And we're certainly building off of past work here. A lot of people have explored data augmentation, self-supervision, and pseudo-labeling for segmentation before. And we're really kind of building on that past work to put them all into the same framework in this kind of flexible pipeline to train segmentation networks. So an overview of this two-step process. So in the first step, we train what I'm going to call an initial segmentation network, F prime. So this is not our final segmentation network, but it is a neural network that we train to segment. And we train F prime using both S and D, the labeled and unlabeled data. With the labeled data, we implement a very standard supervised loss. And then we jointly train a self-supervised loss over the unlabeled data. So we add these two losses together, train some initial segmentation network F prime. And again, I'll give details in the next few slides for what these loss functions are. But once we have that initial segmentation network F prime, we go into the second step of our process, which is quite simple. You basically repeat the same training process, but you first pseudo-label all of your unlabeled data. So this just means you take your unlabeled data D, which does not have manual segmentation masks. You pass it through F prime, which was the network we trained in step 1. And this gives you a pseudo-labeled data set P. So this is what F prime thinks the segmentation masks are for D. We join the pseudo-labeled data set with the manually labeled data set, and then we pass both of those image segmentation mask pairs through the same training pipeline. So we have still a supervised and self-supervised loss, and this produces our final segmentation network F. So let me get into a little bit of the details here about what are our loss functions and how exactly we do this. So the supervised loss function, where we have access to both images and ground truth masks, so manually annotated masks, is very standard. It looks like, super traditional, naive implementations of supervised learning. So we take the image and segmentation mask. This is a cardiac MR image. This is the left ventricle that we're segmenting here. We take the image segmentation mask pair, pass them through some augmentation. So here I'm visualizing rotate, push the image through the network retraining. This produces a prediction, and then we just use a cross entropy loss to encourage the predicted mask to match the ground truth mask. The only update we make to this very standard training procedure is in how we choose augmentations. So augmentations, there's a ton of methods proposed for how you choose augmentations, how you compose augmentations, to kind of eke out the most signal you can from your available labeled data. We implement a process that was proposed previously by others in our group. It's described fully in this ICML paper from last year. But kind of the high level view of this approach to choosing data augmentations is that you apply a bunch of data augmentations, and whichever one the network is most uncertain about, so like whichever one has the highest cross entropy loss, that's the augmentation you choose to backpropagate on. So it kind of forces the network to focus on augmentations that are difficult for it to learn, if that makes sense. So we have this, minor update of how we choose augmentations, but otherwise this is a very standard supervised loss.
Oh, can I ask a quick question here? What's the pool of augmentations that you choose from? Like, are they standard ones that are used in natural images, or?
Yeah, so user can define them. What we ended up with, I'll try to remember the full set. They're standard, like elastic transforms, contrast, jitter, affine transforms, flips, rotates, nothing fancy. Brightness adjustment, yeah.
Okay. And I guess I'll ask a question about this later in your results probably, but I'm curious about which augmentation was most difficult in majority.
Yeah, that's actually a good question. I don't have the numbers in this slide. That was kind of an experiment we ran many months ago, so I don't even remember. What I'll show in my results is the effect of adding this method of choosing augmentations, but I don't have kind of specified numbers for each augmentation. That'd be interesting to look at. You could add a table or something.
Nice.
Okay, cool. And then moving into the self-supervised loss. So here we only have access to the images, so no segmentation masks. And we want to define some task that enables the network to learn from these images, despite the fact that we don't have manual labels. And so here, this self-supervised loss function that we're going to use looks a lot like a contrastive loss or a consistency loss, if you're familiar with either of those. So again, we apply augmentation. Here it's randomly selected, so like a rotate. And then we apply what I'm going to call a segmentation invariant augmentation. And so segmentation invariant augmentations, all I mean by that is that the structures aren't moving. So things like a rotation would not qualify, right? Because the segmentation mask, if one were to exist, would change with the rotation. Whereas, if you just adjust the brightness, so like a brightness jitter, the segmentation mask isn't changing, right? It's just the intensity values of the pixels that are changing. You're not actually changing the orientation of the structures in any way. So here I'm visualizing like a contrast jitter. But it's important that we apply a segmentation invariant operation here and not any augmentation. I'll explain why in a second. But so we apply the segmentation invariant augmentation. We pass each of those images through the network retraining. And you can see I don't have the full network visualized here. That's because we're going to try to take representations from deeper within the network. So not the final output of the network, but some embedding from a little bit deeper inside the network. And we're going to get embeddings for both the original image and then the image that has the segmentation invariant operation. And then we just use a cosine embedding loss to encourage the embeddings of the two images that we pass through to be similar to one another. So all this is teaching the network to do is to be invariant to whatever augmentation we apply before we pass the images through the network. And so this is why it's important to apply that segmentation invariant augmentation, because we want images with the same segmentation mask to be embedded to similar space, but we don't really want images with different segmentation masks to be embedded to the same space. And here for the segmentation invariant operation, we again apply that method of choosing kind of the most uncertain augmentation. I suppose we could also apply it here to the rand augmentation. We did an ablation on that and it didn't really affect performance. So this is, in this case, this is just a random augmentation that we apply in the beginning, and then the segmentation invariant is chosen to maximize uncertainty. So if we
I had a quick question about that.
Sure.
The segmentation invariant part. Like, I don't know if this is a bad idea, but like if we did the augmentation that isn't segmentation invariant, so like the flipping or the rotating, is it a bad idea to then do that same one for the embeddings, like to flip or rotate the embeddings?
Yeah, so sorry, go on, cut you off.
Yeah, that was all.
Yeah, so actually, there is a paper that did something like that. Well, I think it was Florian's paper from his position before he joined Stanford, I think. But they did something similar where you take the output of the network and then you have the original image here and then you do what you're saying. So you flip or rotate, and then they take the output of the network, which is the segmentation mask, and they kind of unaugment that output, which I think is what you're suggesting. So you unflip it, unrotate it, and then you compare the two outputs. That's certainly easier to do with the final output of the network because it's a segmentation mask. It's like a flat image. It kind of makes sense to rotate or flip it. I'm not sure what we would do with kind of higher dimensional embeddings, like how we would simulate a elastic transform or an affine transform or something like that. I suppose you could try it, but the segmentation invariant bit allows us to kind of more easily pull these deeper embeddings and force them to be in the same space.
I see. Yeah, that makes sense. And it probably like the backbone would probably like have to be like a pure CNN, or it probably depends on the backbone too.
Yeah, like, how easy it is to like unaugment, you mean?
Mm-hmm.
Yeah, I would agree with that.
Okay.
Yeah.
Cool, thanks.
So if we zoom back out to the training process again, so we have some label data. We're going to use that for a supervised loss, which is just a cross entropy. We have unlabeled data. As a small note, we also grab all the available pixel data from the labeled data set. And we use that with a self-supervised loss, which is very similar to a consistency loss. It's just this cosine embedding that forces representations of different augmentations to be the same. And we add those two loss functions together and we get some f prime. And then in the second step, we take f prime and use it to label our unlabeled data. So this produces pseudo-labels. We do drop the uncertain pseudo-labels. So if f prime, this is a hyperparameter, but if f prime predicts something for us, we use between like 0.5 and 0.6, or sorry, 0.4 and 0.6. So very uncertain labels for certain pixels. We don't include those in the pseudo-labels, we just ignore those pixels. But we get some pseudo-labeled data P, we join that with the manually labeled data, and then we use the same exact process. So we do keep the self-supervised loss, but the supervised loss has access to more data now because it has the pseudo-labeled data available. And so that training process produces our final segmentation network F, which is expected and observed to be higher performing than F prime because of that access to the pseudo-labeled data. You have more supervised pixels to learn from. So if I go into the results now, there was kind of three main questions that we were aiming to evaluate with our experiments. So the first one is, by how much do we reduce labeling burden? That's kind of the whole motivation for this project. How much can we reduce the number of required labels we need for each image without sacrificing much performance? Two, we have lots of different components in our method, right? How much is each one contributing to the final performance? And then the third question is, we wanted to evaluate the segmentation networks, not just on kind of typical segmentation metrics, so things like dice score or intersection over union, but we wanted to use them to compute things that doctors actually cared about. So I guess to make that a little bit more concrete, if I first describe our segmentation tasks. So we show proof of principle on cardiac MR. We have 4 cardiac MR segmentation tasks visualized here. So we're segmenting the left ventricle in all of these views. Here we're segmenting the epicardium and endocardium, so different parts of the ventricle. And then these are in different views. So the bottom 2 are volumetric scans, although we train 2D networks, and the top 2 are just 2D scans. And so we do evaluate these with the dice coefficient, but we additionally evaluate all of these cardiac functional biomarkers. So these are things that cardiologists look at when they evaluate cardiac MR images and they manually draw segmentation masks. They'll use those segmentation masks to compute these different values. So ejection fraction, for example, is like, what is the fraction of blood that the ventricle is pumping out each cycle? Left ventricular mass, what is the mass of a certain part of the left ventricle? And these functional biomarkers help them diagnose different diseases and kind of monitor cardiac health. So that's what I mean by this third evaluation question: how well do our segmentation networks perform on clinical metrics? We wanted to evaluate on these biomarkers that cardiologists actually care about. So this is our first kind of main result figure, I guess, evaluating labeling reduction. So on the x-axis, I'm sweeping the number of labeled image slices that we have access to for this task. So at minimum, we give it 10 labeled image slices, and at maximum, we give it a little over 16,000. And then on the y-axis, I'm showing the dice coefficient, and each colored line here shows kind of like an additional component of our method stacked on top of one another. So the orange line is the naive method. If you just train using the given number of labeled images and a random data augmentation, what is the performance of the final network? The green line, which is right above it, is if you add in that uncertainty scheme for choosing which data augmentation to apply. The blue line, which is the kind of third highest performing method here, is if you add the self-supervised loss on top of the supervised losses. And then the dark blue line, which is the highest performing in this graph, shows if you additionally add pseudo-labeling. So the dark blue line is our kind of full method. And then, as you go down, as you kind of rip each piece off of the method. And so I think there are kind of 2 takeaways here. One is it's kind of nice to see the contribution of what each component is getting you. So that uncertainty weighted data augmentation gives you a little bit, doesn't give you a lot. It's nice because it provides a principled method for choosing data augmentations, which sometimes can really depend on the user, which augmentations you apply and which ones you allow the network to select. And so it's nice to have kind of a principled method of doing so, but in terms of raw numbers, it doesn't give us that much performance. The self-supervised loss helps a lot, especially in this very limited data regime. But really where we see the biggest performance boost is with the pseudo-labeling step. I think this is not super surprising to anybody who's worked in the kind of weak supervision side of the world, where that's all driven by this idea that if you have more data, even if it has noisy labels, as long as all of your noise isn't very correlated, that can boost your performance. So that's the first takeaway point. It's kind of, what is each component getting you? And then the second takeaway point is just the labeling reduction with the, the full method, this dark blue line. So even with, about 100 labeled image slices, we're not too far off of the 16,000 labeled image slices, which is a pretty significant reduction. And in terms of kind of contextualizing how many patients that number of image slices is, so this task that I'm showing here is a 3D image task. So each image actually contains about 10 to 12 slices. So 100 labeled image slices is about 10 patients worth of labeling. So it's something you can do in, I don't know, an hour or so. Okay.
One question before you move on to the next slide.
Sure.
So in this, like, what's the, in all your experiments, how many unlabeled
Oh,
images?
Great question. Yeah, glad you asked that. I should have mentioned it. So everything that is not labeled, we're using as unlabeled data. Actually,
I see.
Right, we actually kind of use, if you look here, we kind of always use all data available to us as the unlabeled component. So, because we combine, things that don't have labels with things, with all of the pixel data that does have labels. So like for the pseudo-labeled and self-supervised lines, they're always using all images available to them, which is like 16,000.
I see. So if like for the left end of the graph, then only 10 of them are labeled, but the rest are unlabeled. But for the right part of the graph, like what's the difference between, like when you have 16,000 images, what's the difference between your proposed method and the naive method, since you're using all labeled?
Yeah. So we still have a self-supervised loss. So if we say D equals S, like if we have labels for all images in our data set, we'll have a supervised loss for 16,000 images, and we'll have a self-supervised loss for 16,000 images.
I see.
If we only have 10 labeled, 10 of the 16,000 labeled, we'll have a supervised loss for 10 images and a self-supervised loss for the full 16,000.
Got it. Okay, thanks.
You can see that we really don't get any boost in these high data regimes from incorporating the self-supervised loss or the pseudo-labeling step. There might be boosts in other dimensions. Maybe it's more robust, I don't know. But we really only see the unlabeled data helping in the low data regime, the low labeled data regime.
And I think you might actually observe a bigger boost in performance. Let's say you have 16,000 labeled images, but you had, I don't know, more unlabeled images that you can use. I think you'll definitely see. So I think that's actually a pretty cool point, because you might have more unlabeled data, but you're just limiting it to 16,000 in this case.
Yeah, that's a great point.
So one more question, sorry, just to follow up on Aditya's question. So I was wondering if you were doing this, the pseudo-labeling in iterations, or if you were doing it in just one shot, meaning like if you started from 10 images and if you added like 100 and then you added a few more, performance would start to improve, as opposed to like just chucking in all the 15,000 something images.
Yeah. So in the pseudo-labeling / self-training literature, there's all sorts of kind of learning schedules that people have proposed, which is, I think, what you're proposing. So like maybe you start with 10 and then you take, the 100 prediction pseudo-labels that the network is most confident in, and you retrain, and then you take the next maybe 200 or something like that, where you kind of iteratively stack up the pseudo-labels that the F prime, the initial segmentation network, was most confident about. I tried implementing some of those schedulers, and I wasn't convinced any of them were better. I was maybe seeing a few a few tenths of points of boost here or there. I did see faster convergence. So like in total, I was training for fewer epochs, but it wasn't super clean. So one of the things I like about chucking them all in at the same time is we work with our clinical collaborators who kind of want the best possible performance for the least amount of effort. The one advantage of the two-step process is there's like a nice stop point where the user, clinician, expert, whatever, can look at the pseudo labels and quickly say like, yes, this one's good. No, this one's not good. Yes, this one's good. Yes, this one's not good. And kind of remove the very incorrect pseudo labels. And so I haven't very formally run that experiment yet, but I think one advantage of this two-step process is it is more suited to like a human in the loop pipeline if you do need very optimal performance. Whereas some of the schedulers where you kind of iteratively grow your pseudo-labeled training set is a little bit more obtuse. So I suppose that's a long-winded answer. I guess my answer is probably you could eke out some more performance with more sophisticated learning schedulers. It's probably worth doing. I didn't see any with any of the naive schedulers I tried implementing. And if you do want to do a human in the loop system, there might be advantages to having like a very clear two-step thing.
Right. I can totally understand your point of view though. The difference would be like if you wanted to throw in something like curriculum learning here.
Curriculum learning, yeah.
Yeah, if you wanted to like give the network like easier examples to solve and then incrementally add harder examples, that would potentially, sort of help with this as well, this incremental learning. However, maybe another option with the two-step process like you described, where you just give the entire system, entire rest of the images to the system, maybe potentially curriculum learning could also help. So I was just like curious to see if you had tried these different approaches. So thank you. Yeah,
I think you're right. I think your intuition's probably right. You could probably improve performance in those ways. And there's probably more to be done there. I only tried the very naive things.
I actually have a follow-up to what Tejas was saying. So apart, like, I'm thinking of a different kind of iteration. So right now you have a two-step process where you get a course segmenter and then you're using it to train your final segmenter. So is there a benefit to stopping at 2 steps? Like if you use this F and could you get like a more correct segmenter, and was that something that you experimented on?
Probably. So this kind of goes back, like I tried some of the very naive things and maybe saw a few tenths of boosts here or there on some of my tasks, but I didn't explore it fully. So like, if anybody's interested, that's probably the most obvious place to start improving results with the current pipeline. I think those are great ideas.
Okay, thank you.
Oh, sorry, just one more question. I just realized, well, this is actually with the network training itself. So one of the things with training the network and adding more labels to it, as well as, continuing training from a previous checkpoint, is if it gets stuck into a local minima as opposed to the global minima, you effectively will start drilling into like smaller and smaller locations, and you won't hit the optimal global minima.
Yeah.
So I was wondering if you had you were doing the training from scratch all over again every time you started to do pseudo labelings, or if you were like starting from the the lowest validation loss or whatever you do for training.
Yeah, we do start training from scratch for exactly that reason.
Okay, gotcha. Thanks.
Yeah. And I guess you would probably want to do that if you did do kind of more steps as was suggested, or maybe some more sophisticated learning. Okay, cool. Okay, so this table is also trying to show labeling reduction. As I mentioned, we have 4 tasks. So this for cleanliness was visualizing 1 task. These are all 4 tasks. So the top row is if you're at that 100 labeled image slice, remaining unlabeled images training point. The fully supervised is if you use all labeled data you have access to. And then the final row, labeling reduction, is what is the % difference between the fully supervised data set and the 100 slice data set, labeled data set. The reason the labeling reduction changes is because we have slightly different data sets for each task. So if we look across the board here, on all the tasks, we're within about a dice point of the fully supervised performance. The highest labeling reduction we have is for the largest data set we have access to, which is the SACS endocardium task, which is what I was plotting here. But that's actually kind of intuitively, that's the biggest gap we have between the proposed dice score and the fully supervised dice score. Actually, in one of the tasks, we have a tiny bit better performance with the proposed method with only 100 image slices as opposed to the fully supervised.
Two questions. Actually, this is really interesting. So with the performance, well, there's labeling reduction, obviously, but I was wondering if you, in your proposed 100 data set, if you, instead of randomly choosing 100 data points, if you gave the network like maybe the hardest examples to solve, do you know what I mean? Like
For
there's
sure.
like picking the right types of examples, and I'm sure there's like a bunch of research on this. I know that there's a bunch of research on this in CDPR, but I was wondering if this might actually, help the network learn more discriminative and informative parts of the images to segment.
For sure. And I need to run the experiment, so I haven't had time. One of the reasons the clinical collaborators are excited about potentially this using this pipeline is for what you're getting at here, which is if they notice that the network does not perform very well on like a certain disease type or a certain patient type, which I'll show in a slide that is the case. It's true, it doesn't perform well on a certain disease type. It's much easier to label one image stack of that disease type, or maybe 3 to 5 image stacks of that disease type, and put them in as label data and kind of retrain. So potentially you have more control over what examples, the kind of labeled examples that you choose ostensibly have a lot of influence over what the final network performance is. If you randomly choose them, which is what we're doing, we're just randomly choosing 100 image slices, the final performance doesn't change that much. But if you're very targeted, so like I'm going to include disease A, disease B, and 3 normal patients or something like that, maybe you could be more robust and have a little bit more control over exactly how your network performs on harder images. So let me just go to that slide since we're talking about it. So here's some visualizations of places we don't do very well. And there's kind of 4 categories of errors that we notice we make. So what I'm plotting here is each column is a different category of error. The top row is just the image. The middle row is the prediction by the network we proposed trained with 100 image slices. And then the bottom row is if you train with all available labeled images. So the categories of error, the one I was just talking about, this HCM case. So one place we often don't do super well is with patients who have very abnormally small left ventricles. So typically the left ventricle, like if you look here in this 3rd row, it's like nice and big, or these circles, they're nice and big, they're quite clear. These small left ventricles, like here in B, they occur maybe like, I don't know, 1 in 15 patients or something like that. Don't quote me, that's just from what I feel like from looking at all the images. But these tiny left ventricles are kind of hard to segment, and they're hard for doctors to segment too. So sometimes we like totally fail, sometimes we just don't do great, like what I'm plotting here. Turns out the fully supervised network also doesn't do great. It has the exact same error mode on those patients with small left ventricles. And so, yeah, I want to run the experiment like, okay, let's add patients with small left ventricles into our tiny label training set, and maybe we'll do a little bit better on those. Actually, maybe proportionally we'll do better on those than the fully supervised, since adding 5 patients to a fully supervised network, is just a drop in the bucket of labeled images. Other common error modes while I'm on this slide. So none of these are surprises. So sometimes the images have artifacts in them, or some type of imaging error. So in this case, I think the patient has some sort of device implanted or something. The contrast between the left ventricle, what we're segmenting, and the background is super low. So our proposed network actually doesn't predict anything at all. The fully supervised manages to get it right. So that's an interesting difference between, in an error case, between our proposed method and the fully supervised method. Imaging error is kind of the same thing, so that, there's something abnormal with the image based off of the imaging protocol. And then this first case, I'm not going to go too deep into, it's kind of cardiac specific. So let me go back to where we were. So this is the labeling reduction table. These are the median performing images for each task. So we are just looking at failure cases. So these are, not failure cases. If you just pick out the median performing case according to the DICE score, you can see qualitatively how we're doing. Typically, the segmentations are pretty good. There's a little bit of disagreement at the borders. So the dark blue color is correct segmentations. The bright orange color is false negatives. So we didn't predict where we should have. And the cyan color is false positive. So we predicted where we should not have. And as I mentioned at the top, there's a good amount of inter-observer variation as well with these tasks, where you'll see these, variations in the edges. So overall, it's nice to see like pretty strong qualitative agreement. Next, I'm going to go into that kind of third axis of evaluation we're interested in on the clinical metrics. So as I mentioned, we have 5 cardiac functional biomarkers that tell you things about the structure and function of the heart. So ejection fraction was that thing about how much blood the heart is pumping on each cycle. And what I'm plotting here are, if you take the segmentation masks produced by the networks that were trained with 100 labeled image slices, and you compare them to the clinical metrics that were recorded by an expert after manually annotating the segmentation mask onto the image. And so I'm plotting the correlation on the top row and the Blaine-Altman plots on the bottom row for these 5 different functional biomarkers. And to kind of contextualize these figures, I'm going to also quickly flash on screen. This is the intra-observer variability. So if you take the same expert, you have them manually segment the images, record the values, wait a few days, look at the exact same images, manually annotate and record values again. What is that intra-observer variation? Again, I'm showing the correlation, the Blaine-Altman plots. So now that we have kind of some added context, on the top is the expert versus our proposed method, and the bottom is the expert versus themselves. And these are, the correlation plots, obviously, with the Pearson correlation coefficient in the top left. And you can see pretty kind of similar correlation, strong correlation between the proposed method and the expert. If we look at the Blaine-Altman plots instead of the correlation plots, one thing that quite obviously sticks out is that we have some added bias with our proposed method that we don't see with the intra-observer variation. So even though like the standard deviation is pretty similar between the proposed and the expert variation, we have this kind of additional bias with the proposed method that we don't see with the intra-observer variation. One potential reason for this is that the test data set I'm plotting here was all labeled by the same annotator. So with all segmentation tasks, oftentimes there's kind of conventions, like the segmenter has some sort of convention for where exactly they start segmenting and which slice exactly they stop segmenting. And so if you don't exactly match that labeler's convention, you get these biases, where obviously if you have the same labeler label the same image twice, they're going to repeat the same convention, and so you don't get a bias. So to kind of back up that claim, here we have a much bigger data set where the test data set was labeled by many different annotators, and we do see reduced bias with the proposed method versus the expert. So again, we see strong correlations on this bigger data set, a little bit of a reduced bias. We still have a bias on this left ventricular mass metric, which there's some intuition for why that is, but we'll go into for sake of time. One other thing I'll note on this.
May I ask a question here?
Sure, yes, please.
Yeah, so since you have like multiple annotators here, did you get a chance to look at the model versus the expert difference versus interreader?
Yeah,
difference?
Yeah, I don't have those plots because I didn't have exactly which images were annotated by which annotators. I just didn't have that available to me in the CSV I was given. For this data set, which is the smaller data set, they actually do show, so the data set was published prior to this work. So there's a paper I'm happy to send kind of just evaluating on this small data set. And they do show intra-observer, inter-observer, and observer versus fully supervised model variation. And as you're kind of suggesting, the inter-observer variation looks quite similar to the fully supervised variation, but I do not have those plots for this data. Okay, one final note I'll make on this data set. So an additional experiment we were running here was we wanted to make sure that the proposed method, even though it was only trained with a small number of labeled images, had some capacity to generalize. So this data set was collected at a different healthcare center than the data sets that supply the training data. And so it's just kind of reassuring to see that we do see similar correlation coefficients and Blaine-Altman plots for this generalization data set. We went over the error modes. So kind of wrapping up, I think there are some strengths to the system. So one, it's convenient if you're training segmentation networks. This might be a nice way to lower your costs, or at least get some sort of semi-automated segmentation pipeline up and running. One thing that was interesting here is that we were able to evaluate these clinical metrics and evaluate on a generalization data set. And so we're able to show and able to see that the semi-supervised methods that work pretty well in distribution also kind of extended well to these clinical metrics and to data sets from different healthcare centers. And then lastly, it's a pretty flexible method. As long as you have some labeled and some unlabeled data, all we do is manipulate augmentations and loss functions. So you can use any type of input data, any segmentation architecture that you like, or that is kind of suited to your specific segmentation task. That being said, there's, as always, plenty more to do. So I think there's been great conversation in this talk, which I appreciate everybody's thoughts about, within the existing pipeline, how can we improve performance? And it seems like, that curriculum learning, how do we handle the pseudo-labeling process, and also which initial images we use as label data. That's kind of obvious places to work on improving performance. So I appreciate all the thoughts there. Other places we've talked about for future work. One is just extending this to more segmentation tasks, finding other places where segmentation maybe isn't often used because it's considered to be a very expensive type of task, but if in fact it's not that expensive, if you can train segmentation networks with just like 10 patients, what other use cases does that open up? And then on the technical side, some interesting things that came from this. So we do have, pretty strong aggregate performance, but we saw notable error mode. So we're failing on patients who have a certain type of abnormality in their left ventricle, certain types of artifacts we don't do super well on. And so how can we identify those errors and those patterns of errors? And then how do we fix those errors? Are also places we could improve. Okay, so that's all the slides I have. If there are more questions, happy to take them. Otherwise, I appreciate everybody's time and questions and suggestions.
Yeah, I actually have one more.
Yeah, go for it.
So the failure modes where you had one of the parts of the cardiac, the left ventricle, I think. Oh yeah, I don't know if it's a pacemaker, but the one with the imaging artifact where it detected a false negative entirely. I'm assuming that this sort of error might occur during the pseudo-labeling process while the network is training too, assuming that some images might contain this. And, I just wanted to maybe get your thoughts on how do you sort of circumvent such a problem? And then, sometimes it's just the cost of doing business, it just comes with the territory. You will get some false negatives and false positives. But the question is, how do you maybe intelligently identify such issues? And I was wondering if you had any thoughts on that.
Yeah, so it's not the most technical answer maybe, but what I was kind of suggesting earlier for this, if there's some sort of semi-automated approach, so, manually labeling 16,000 image slices takes a long time. Maybe we can automate 12,000 of them and the pseudo labels are good enough because the images aren't that weird. And maybe we just have some sort of semi-automated pipeline where we straight up have a doctor go through and look and flag the ones that are incorrect in the pseudo-label data set. Or one thing, just kind of like back of the envelope or back of the Jupyter notebook test I've run is if you surface the examples that the network is most uncertain about, so it has the most number of predicted pixels, very close to 0.5, it's super uncertain about them. If you just surface those uncertain examples, they tend to be the worst performing examples. So that's potentially one way you could kind of surface incorrectly labeled examples and then have a human in the loop to go and either fix them, or if you observe something like the left ventricle abnormality case, you could add a few left ventricle cases into the labeled data set. So I think for applications like medicine, where you do really demand high performance on a lot of subsets and errors are bad, I think this kind of approach to semi-automated labeling dataset generation is promising because if you have a human in the loop somewhere, that you have a data set that is well labeled and with labels you can trust. But they didn't have to go manually label everything. There's also work on, actually, I don't remember who presented it. Somebody in Amy or IBIS is doing this work, and there's other outside of Stanford doing this work too, about training with noisy labels. So if you know that some part of your data set has incorrect labels, like how do you ignore those during training? And so you could potentially incorporate that sort of thing into training, especially for the second step where exactly that, that you have some incorrect labels. We're doing like the most naive thing where you ignore the uncertain pseudo labels, but there's certainly more, I guess, sophisticated training you could do.
I'm wondering how important is the self-supervised loss in the second step? Do you do any ablation on it?
Yeah, I don't have those numbers on this slide. Off the top of my head, I remember we still had like a 0.5 point-ish boost from keeping it in the second step. Enough that I decided it was worth the training time to keep it in, but I don't have those numbers in this slide deck. I should put them in the slide deck and also in the supplementary of our paper. So thanks for the suggestion. Yeah, it was still helpful. And like I said, there's, I'm not sure of this. It's something that, an experiment to be run, but there's potentially other benefits of having the self-supervised loss. Potentially you're a little bit more robust, potentially you generalize better, those sorts of things. And so that's also like another dimension to evaluate performance on before removing the self-supervised loss. But I should add those numbers.
Mm-hmm.
Thank you.
Great. Are there any more questions? I guess if not, let's thank Sarah with the round of virtual applause. Thanks, Sarah, for presenting your work. And I think we had a very interesting discussion as well today. So thanks, everyone. And we'll put up the recorded talk on YouTube. So if you have more follow-up questions or want to read more about Sarah's work, you can always follow up with her. We also have a form on our website where if you have further questions, you can fill it out and then we'll get back to you as well. So see you next week, and thanks again for attending today.
Yeah, thank you all for your time and thoughts.
Thank you.
Thank you.